All right, welcome. And I'm here today with Dr. Nikki Lay, who is a practicing urologist at Austin Diagnostic Clinic. And we're today going to talk a little bit about the management and diagnostic testing involved in recurrent urinary tract infections. So Dr. Lay, I wanted to start off by just asking sort of when you see a patient who comes in, who's been referred to you for recurrent urinary tract infections, what's kind of your initial evaluation or initial thought process when you're looking at that patient?
Sure. Now, this is a patient that I will see about 3 or 4 times a day. It's very common, especially, I believe, in women who are practicing urology. So when I have a patient who's been referred for recurrent UTIs, I first try and get an understanding of what that means. Is this someone who had a confirmed culture and that was treated and the symptoms came back almost immediately after treatment, or is this another person who's had 3 or 4 infections during the year? If it is someone who has had multiple infections and I have access to their cultures, I will generally look at their cultures to see which organisms have been involved. And if it looks like frequent infections and not truly persistent or recurrent infections, then my thought process is, do we need to do an evaluation of the upper tracts, look for other risk factors such as stones, and then I also check their post-viral residual, make sure they're emptying well. I will do a speculum exam to check for any stricture of the meatus as well as for prolapse. So all of these things can affect a person's ability to empty. During the speculum exam, I will also look at the tissue quality in a patient who is postmenopausal, or perhaps even a patient who's premenopausal but has some patients who may have a atrophy symptoms because of birth control or other medications. So I'll look at their tissue quality to get a better understanding of what their risk factors may be. And then in indicated patients, I will also consider a cystoscopy. So that's part of my initial evaluation, but with the advent and introduction of molecular diagnostic tests, I've also integrated these into my initial evaluation, because what I've found is there are some patients who may have been treated for one organism initially, but their symptoms came back quite immediately because there were other organisms which may not have been identified. So I'll use in my situation, I tend to use the guidance culture. I'll use the guidance culture to identify additional bacteria which may be fastidious and difficult to identify on a traditional culture. The other, go ahead.
No, please, why don't you finish and then I can ask.
Yeah, so the other group of patients that I have found to be challenging are those who have the characteristic symptoms of urinary tract infections. They say, I've had infections throughout my life and I know what they feel like, but my cultures either come back as negative or mixed flora, and I'm told that it's a contamination. And in those patients, I will definitely offer the guidance culture, because I'm finding that this mixed flora, especially when they're high numbers, 50 to 100,000 CFUs, may actually represent patients who have multiple bacterial infections, and the traditional culture has a difficult time delineating the various species. And these are the 2 groups of patients that I feel really benefited from this particular type of technology.
So for you tend to use that molecular diagnostics specifically in those 2 groups of patients in that sort of more initial kind of setting. But the patients who have the infection and it resolves, that's a little bit different. Then you're looking more for risk factors for recurrence. Is that a summary?
I will also use the guidance cultures in patients who do have frequent urinary tract infections, even with a different species identified on the traditional culture. And that is because I believe that, and this is in looking at the data as well, that some of the patients who may be identified as having an E. coli infection, for instance, actually may have other subspecies that aren't identified. And when they're treated for the E. coli, their symptoms improve, but because they're I guess, unidentified bacteria, their symptoms come back quite quickly, and that might cause them to have an infection month after month after month. So I will use the guidance culture or molecular diagnostics in both groups of patients as an initial evaluation. By the time they get to my office, they've already seen multiple practitioners, so I feel it's my duty to offer them this test right up front so that it can potentially elucidate the etiology.
That's great. When you get the test back from these, from guidance or from whichever molecular diagnostics you use, is there any general pattern to the kind of results that you're seeing? Do you notice anything? Do they tend to be sort of multifloral, or is there a different organism that tends to come out that you go, oh, that one's the one I need to be treating?
So there have been a couple of things I've noticed that have been very, I guess, insightful for me. First of all, the majority of cultures do reveal multiple bacteria, and so the multifloral. So that caused me to have a conversation with the Diagnostics PhD individual. I think his name is Dave. I can't remember his name exactly. But what he explained to me is that Diagnostics is only reporting known GU pathogens. So instead of reporting various bacteria that you can find in the vaginal vault, that these are known pathogens that cause symptoms. So that gave me some reassurance that we're not receiving information about bacteria that won't cause any symptoms for the patient. So that's one thing. So most of them are multifloral. And I have started to see, bacteria that I've never seen on traditional culture. Actinotignum, Alloscardovia. We can like edit all of these things. I don't know how to edit them. They're basically bacteria I have never seen on traditional culture. And you'll see maybe E. coli and Klebsiella as one of the bacteria that are identified. That's why I believe that these patients have multiple bacteria, but only some of them, only the predominant ones or the ones that flourish well in a traditional culture are being identified and treated, and that's why the patients have persistent symptoms and a new infection in a short period of time.
So when you get your testing results back, are you also getting feedback about what is the appropriate antimicrobial treatment of these other organisms outside of sort of the classic E. coli and Klebsiella?
Yeah, so one of the benefits that I find of the guidance culture is that they look at the antibiotic sensitivity of that particular milieu. So as it was explained to me, bacteria have different antibiotic sensitivities and resistance depending on the environment in which they reside. So if you have one combination, if it's just E. coli versus E. coli and Enterococcus, the two bacteria together, that combination can change the antibiotic sensitivity. The way that the antibiotic sensitivity is reported in the Diagnostics test is that phenotypically pooled sensitivity. This is what this group of bacteria will respond to. And that's just not, that's a thought that has never crossed my mind in the traditional teaching of, interpreting cultures and treating urinary tract infections. It was always like, okay, if it's sensitive, it's going to be sensitive. And the fact that there's this interaction that can affect sensitivities has never crossed my mind. So I find that to be an additional benefit, this pooled sensitivity data.
So once you get this data back, you've got your patient, they've had these recurrent infections, you get this culture back that has this mixed group of bacteria, and now you've got some recommendations for treatment. What do you do then? How do you treat the patient at that point?
So at that point in time, I use my typical algorithm for choosing an antibiotic. If I can avoid the fluoroquinolones, I try not to use them, only because some of our teaching has recommended that we save those antibiotics only for patients who have no other options. So they give me a grid of the various bacteria that are identified. They also give me a grid with the pooled sensitivity data, and they give me data on which antibiotics tend to treat which bacteria from a research standpoint. So maybe not the pool sensitivity, but in literature, what has been shown to treat these bacteria the best. And then they also give me information whether or not a resistance gene has been identified. So I pull that information together and make the best choice for the patient, also taking into consideration their allergy profile and the other medications that they have to avoid any interactions.
Great. And what's your sort of experience been in treating patients using this kind of guided methodology?
I find that I am able to resolve irritative voiding symptoms on a first go much more frequently than I did in the past. So for instance, I have a couple of patients in mind who I found to be very impactful in my experience with the guidance culture. One particular patient was in her 30s and she had had a hysterectomy back in 2018. And since her hysterectomy, she had had recurrent UTI symptoms. And once in a while, her cultures would be positive, she would be treated, but then her symptoms would come back. But throughout that time, her bladder pain, urgency, and frequency never fully resolved. And she was referred to me by her gynecologist. So I did a molecular guidance test, and I found some atypical bacteria, Mycoplasma, ureaplasma, as well as Strep viridans. I treated her with a doxycycline for 10 days. And this was the only time she had been pain-free since 2018. And I have a collection of patients with very similar experiences, especially after either a urologic or gynecologic procedure. And after the procedure, they have this persistent pain, and the thought is, well, is there a bladder injury? So, with that history, I do usually scope them, especially if they've had hematuria, to make sure there's nothing anatomically abnormal. But it's to the point that the gynecologist will send me their patients now with the hope and intent that I will be able to find an infection, an unidentified infection that can explain their symptoms. Like they're sending me these patients for this particular reason.
That's great. Do you find that that one course of antibiotics is sufficient to kind of take care of things, or do they need to kind of have some additional suppressive or prophylactic medication to keep the infections from coming back?
I would say that it's a mixed group. For the patients who prior to had no issues with the treatment of urinary tract infections, for example, the patient that I described to you, prior to her hysterectomy, if she had a urinary tract infection, she would be treated and she would feel better. This was the first time she had had persistent symptoms after multiple treatments. In this patient, when we identified the abnormal bacteria and treated it appropriately, she stopped having symptoms. But there are some who have a long history of frequent urinary tract infections. And even though I identify bacteria initially with the molecular diagnostic test and treat it appropriately, they may then have another infection, like several infections afterwards. Maybe not as, they don't recur as quickly, but they do recur. And in those patients, I will make sure they're on estrogen replacement, if appropriate, potentially some supplements like D-mannose or probiotics, and then consider prophylactic antibiotics on them for 3 to 6 months. I try not to keep them on long-term prophylaxis unless they've failed, unless the infections recur when I take them off.
That's wonderful. Well, thank you so much for sharing your experience. That's incredibly insightful and very educational for me, and I'm sure for everyone else.
Oh, you're very welcome. I hope this helps other urologists out there, because I know in my personal experience has been very, very much a challenge taking care of these patients. And there's one other thing I would like to mention. This experience has made me wonder if some of the patients who have been previously diagnosed with interstitial cystitis may have potentially just had an under-treated, under-recognized urinary tract infection. So it's something for us to consider moving on.
Absolutely. I think there's a ton more we still need to learn about this, and I think that's as good a hypothesis as any we have regarding interstitial cystitis. And I hope we will continue to further that discussion and that research.
Great. Well, thank you so much for the opportunity. I appreciate it.
Thank you so much, Dr. Lay. Appreciate it very much.